Auch von meiner Seite möchte ich mich bedanken. Schluss mit dem Entertainment. Lynn, I start again. Also the second time I'm honored to introduce you, Dr. Lynn Snyder-Mackler from the University of Delaware. Thank you that you are here. Your CV is a long list. So Mario gave me really a long list of your work, more than 250 research articles, books, monographs, multiple award winner from the Sports Physical Therapy Association in the US. So she will talk about the knee and the ACL and give us an update. What an incredible crowd, Lynn, no? So thank you thank you to be here to celebrate the last 20 years, and Lynn, also the next 20 years. The stage is yours. Please.
I'm here for the next one.
Me too.
Good morning, everybody. Wow. Just like in my classes, nobody likes the front row, right? It's just empty. I was definitely not a front row person in school. So I'm a clinician, right? And I've been in a academic position for almost 40 years. All of my research, all of it, is spurred on from a young clinician who couldn't figure out why someone whose quads worked perfectly well would go into surgery, have a partial meniscectomy, and the next day couldn't activate their quads. So what was it about an intra-articular knee injury, meniscus, ACL, cartilage, osteoarthritis, that has this symbiotic relationship with the quads, and why is it that makes it so hard for us to rehab these folks? So, I mean, I've been chasing this mystery of the quads for, as I said, 40 years. So today I'm going to talk about optimizing outcomes and minimizing re-injury after acute ACL rupture, evidence from two of our major trials. The Delaware-Oslo cohort, which is a 20-year study now. We're just analyzing our 10-year results. A cooperation between the University of Delaware and Oslo University. And then our ACL sports trial, which took all of the evidence from the work that we've been doing before and added one more thing, and the outcomes were predictable and outstanding and done with pretty easy rehab. Nothing, not easy for the patient, but not technically difficult. I have only one, I'm a consultant to Miach Orthopedics. Otherwise, just research grants. Okay, so you can copy down this site, or you can just put in University of Delaware Physical Therapy Clinic, and when you get to that, there's a tab that says for health professionals. Hit that, and underneath there are practice guidelines, among other things. And those practice guidelines are organized by joint, right? So knee, ankle, shoulder. And we update these, we update them on an every few year basis, so you'll know when it'll say updated in all capital letters for a while when when we put a new one up there. So this is the beginning, the first top page of our updated ACL practice guidelines, which came out earlier this year. And we'll look at all eventualities, but basically, the rehab is for the primary surgery, right? And then you'll see secondary surgeries, and then there's an appendix that addresses how you modify this protocol if someone's had, let's say, a meniscus repair, something that's quite common, right? And then expected number of visits, outcome measures that we expect people to use, and then our operational definition. So in each section, each phase, there'll be a phase goal that says, by the end of this time period, your patient should have met these clinical milestones, okay? Now, this is not a protocol. These are practice guidelines. Think about it like a recipe to bake a cake. There are many, many ways to bake a chocolate cake. Maybe your grandmother's recipe is a little different from mine, okay? So what this sets up are the expectations, the phase goals. And if your patients are not meeting those phase goals on a routine basis, then here's a recipe for helping them meet those phase goals, okay? So it doesn't mean you have to follow exactly what we're doing, but you should pay attention to the precautions for each phase and the goals, and then figure out if you're doing it with your rehab the way you're doing it, then keep going, right? But if you're not, here's a way to modify your rehabilitation to achieve those goals. This is the example. This is in the appendix where you see the modification. This is again, available free, okay? So you can download it anytime you want. The modifications for some very common and some not so common, like meniscus transplant and concomitant chondral repair. How you would modify the practice guidelines that preceded this. Okay, oops, sorry. And let me go back one. How do we go back? Back, there we go. So in conjunction with posting these new practice guidelines, we published this paper earlier this year in Sports Health. I guess late. It was published online earlier this year, but just published in the September-October issue of Sports Health. And this gives you the clinical data that we base our milestones on, because every time we reevaluate our practice guidelines, we need to look at whether our own patients are meeting those clinical milestones, right? So, and we did adjust one of them. Biological healing, which is very important. Here in particular, we're talking about graft healing. And then how we use this to inform a return to sport guideline. So this is just a quick snapshot of the validation data that we did. So when do patients get to a trace effusion? We divided them into two groups. ACL reconstruction up to and including a partial meniscectomy, and then plus a repair is the other, because there's lots of, some surgeons change the protocol substantially for meniscus repair, but we wanted to see in our hands with the protocols that we use, with the practice guidelines that we use, when did they meet these milestones? And it turned out, in terms of effusion, full active knee extension, full passive knee extension, and a ADLS score greater than 80%, they were really similar. And we're postulating that because the people who got meniscal repair were younger than the population as a whole, right? So it may just be that they were younger, more active, started out better, ended up better. But it really didn't matter whether following these practice guidelines, whether they had a meniscus repair or nothing. They hit these guidelines at the same time. So trace effusion, about 3 months. Active knee extension, 1 to 2 weeks. Passive knee extension, 1 to 2 weeks. And ADL scores, again, around 3 months. They were at 80%. Now, the bottom, we actually published a paper on one of our other subsets on this. What you can see is that patients who've had bone patellar tendon bone graft take longer to meet clinical milestones and longer to meet return to play guidelines. So here you see, for them, just quad strength. To get to 80% quad strength, it's, for the bone patellar tendon bone, it's 3+ months. For the hamstrings, it's 2, okay? Hamstring allograft, again, same, basically. And then for greater than, and then again, separate that out a little bit. And again, we have the meniscus repairs separated out, right? The people who had repairs. Again, not too much difference there. It's really the graft site that's driving this difference in quad strength. So week 30 for bone patellar tendon bone to get to 90%. So that's basically 5 months, 6 months, I guess, 6 months. And again, a little bit over 3 months for the hamstring allograft. So just keep this in mind. It's not your rehab. This is a real phenomenon. So here's Delaware also cohort. This is the first one. This was started. We started the collaboration in 2001. My Arne Risberg from Oslo and myself, Lars Engebretsen, was the orthopedic surgeon in charge of this in Norway, and Michael Axe, in the second row right there, was the orthopedic surgeon in Delaware. We had 300 patients followed prospectively, 150 in each location. We did impairment resolution. We screened them with HOP tests and strength tests. We did 10 sessions of neuromuscular and strength training. This is all pre-op. We did functional testing again, and then the patients made a decision about surgery or no surgery. After that little bit more prolonged rehab beyond a quiet knee, and they either had surgery or no surgery, and we followed them up at 6 months, a year, 2 years, 5 years, and now we're finishing up 10-year follow-up. This is a nice thing about international collaborations. You get to visit each other. So this is when ESCO was in Oslo in 2010, and we went a little bit early and went up to the Lofoten Islands above the polar circle. And this is midnight on January 6th, and we couldn't stare down the sun. It was still up. Okay, so let's get down to brass tacks here. We all know the numbers about re-injury. The overall rate, graft rupture plus contralateral rupture, is around 30%. And I would postulate that that's a low number, because in all of those studies or registries, they assume the denominator should be exposure, meaning return to play, right? That assumes, those numbers assume that return to play was 100% in that sample. And we know for sure that it was not 100%. We know it's probably 60 to 80% depending on the level of play, professional to amateur, okay? So those numbers are deflated and still incredibly dismaying. And for those who return after revision surgery, the chance of a third injury is pretty much the same, and a fourth, by the way. And we've all seen those, I think, in practice, speaking of dismaying. So we know these numbers, but our patients don't. Our patients, more than 90%, expect to return to the previous level of play without re-injury. And more than 95% do not acknowledge any increased risk of knee OA. Again, they've got about almost 100% risk in their lifetime as a consequence of this injury. So there's a big mismatch here. So first comes education, and that prolonged preoperative rehabilitation beyond a quiet knee gives us an opportunity to discuss this with our patients, to give them a bit of a reality check. And then actually with all stakeholders. So that might be parents in the case of our adolescent patients. In fact, it is parents. So first comes education, not just about this dismaying data about re-injury, but more importantly, what we can do about it. And our algorithm, the Delaware Oslo cohort, centers around shared decision-making. So this is a really nice infographic produced by the NATA and the National Athletic Trainers Association in the US, the OA Action Alliance, and the American Academy of Orthopedic Surgeons, and it is freely available. But it goes through in a very systematic way what we know about ACL injury and what it is important for our patients to know. So what's the biggest risk factor for a second ACL injury? Returning to level 1, jumping, pivoting, and cutting sports. By a country mile, it is the biggest risk factor. Some people say younger age, but younger age is just a surrogate for return to play because younger players return to sport at much higher levels than older players. So it's not just age per se, it's age facilitating a return to level 1 sport. So here's the conundrum. Number one risk for ACL re-injury is return to level 1 sport. It's actually ACL injury as well. It's a number one risk for primary injury. But overwhelmingly, our patients have ACL reconstruction in order to return to sport. So here's what we did. So our management algorithm is we got to a quiet knee. We wanted no effusion, full knee range of motion, quad strength greater than or equal to 70%, and the ability to hop on an injured leg without pain. And again, we use this time period to start to counsel our patients about the expectations. So this is preoperative rehab phase goals. Again, back to our new practice guidelines. These are what we expect. And then patient education. It's important to prehab for ultimate post-op. What to do using this again immediately after surgery, anticipated return to sport guidelines, and expected outcome. So that we're covering that return to prior level of competition is often difficult but possible is how we present this, and that there is an osteoarthritis risk. Okay, so we then do a screening examination, HOP test series, number of giving way episodes since the incident injury, use this KOS knee outcome survey activities of daily living score, and a global rating of knee function. That question it's a single question that says, how is your knee functioning compared to how it was functioning before you were injured? So it's a pretty tough scale from 0 to 100, right? I mean, they're in the 20s to 40s immediately after injury, right? Their knee is not functioning well at all. So we divide them into potential copers and non-copers. And to be a potential coper, they have to have less than one episode of giving way, or less than or equal to, no more than one episode of giving way since their incident injury. 80% on the time top, ADLS score greater than or equal to 80%, and 60% on the GRS score. After that, we do 10 sessions of what we did was perturbation training, a form of neuromuscular training, and strength training and agilities, and then retested. If they failed any of those, they were considered to be a non-coper. They were classified in that way. So here's the treatment algorithm for level 1 and 2 athletes. Patients are educated on the outcomes of operative and non-operative management, and then it divides up and is the patient planning ACLR. Once the impairments are resolved, we do that prehab, including progressive neuromuscular and strength training. And ultimately, and then we retest them. And the 10 sessions are bi to tri-weekly, right? And you're assessing whether they're tolerating it just like you would any other progressive rehabilitation program. If they start to swell, if they have knee pain, you're going to slow it down, right? Give them more days rest in between. So this was published in 2019, looking at what's the effect of that rehabilitation program on their performance in pre and post in these HOP tests and strength, and does it change their COPER classification? And turns out that nearly half of the non-copers converted to potential copers over that roughly 5-week, 10-session period. Okay? And COPER classification was strongly associated with 2-year success. Okay? Potential copers had 3 times the odds of success of non-copers. So just doing that 10 sessions of rehab after a quiet knee, you up the chances of about half of the non-copers to have a successful outcome after ACLR. So what do we do? What do we do after reconstruction? This is our immediate post-op week 1. You see the phase goals up there. They're milestones. And then here, this is what I meant by it's a recipe. We have treatment strategies, right? You can fit yours in there pretty easily. And we are really, I'm going to get more into what we do. So inflammation control is number 1. You really have to get the effusion under control. Full active knee extension with good patellar mobility. You want a full patellar glide up into the suprapatellar pouch. You need to pay particular attention when the extensor mechanism is used as a graft. Quad strengthening and gait training. We use electrical stimulation. We use it at a very strong, very high intensity, and we do not superimpose it on a volitional contraction. That we want electrically elicited force of at least 50% of the MVC. As I said, aggressive elevation and effusion control. They do this at home too, leg way up the wall. Quad strengthening. Open and closed chain quads starting day 1. Okay? Everybody, right? You're therapists. You're therapists. The orthopedic surgeons perpetuated this nonsense, okay? Let's start there. Sorry, honey. He didn't. Oh, my goodness. So we wrote this paper, Brian Oren from the University of Kentucky and I wrote this paper last year in JOSPT. And the title says it all. Who's afraid of the big bad wolf, right? You're not, right? Are you? No. How about if we talk about the science? This is what, first of all, these are the old papers from the University of Vermont in the 90s. They always show this chart. I don't know can you see it? Okay. See those numbers? Isometric quad contraction at 15 degrees, so open chain, 4.4, with a 30 Newton meter boot. Squatting with a sport cord. What's that? Closed, right? 4.0. Got it? Active knee extension with a 45 Newton weight boot, 3.8. Okay? Is open chain more strain than closed? No? Is the answer? Okay, so let's start there. But now let's go to some more recent stuff. So this is stuff from Lou DeFreit's lab at Duke University in the United States, and they are able to use biplanar fluoroscopy to measure the strain on the ACL when people are doing various activities. This is walking. So if you look at the top graph, that's a typical time series curve of the flexion and extension angle of the knee during walking from heel strike through heel strike, right? Stance, swing, boom. Relative strain of the ACL twice during gait, right before mid-stance, right before full extension and stance, 13%. Remember the number before? Okay. And 10%. And another study from this same group, everybody's incredulous. I can't see these faces up here. It's amazing. In vivo attachment site, this is looking at it slightly differently, but here you see the same thing, strain of 5 and 12. Okay, remember? 4. Okay. So, open chain knee extension with resistance, 4. Squatting with a sport cord, 4. Mini squat, 3.6. Walking each step, 13 to 14%. Okay? Now, just get the Big Bad Wolf article. It's all in there. Okay, so what's the consequence of only doing closed chain exercise with your patients? And, by the way, if you don't do it, you probably don't do open chain. You also probably don't have instrumentation to measure the quads, so you don't really even know what they're doing because you can't measure it with your hands or with a handheld dynamometer very well. So here's the problem. So this is a very elegant paper from a combination of locations from Cincinnati Children's Hospital and the Ohio State University in Ohio. Both of them are in Ohio. And this is, Cincinnati Children's has a lot of pediatric ACL patients, right? Young, very young. So they divided them into pediatric, adolescent, and young adult. And they looked at the milestones that we use to begin their return to activity progression, right? 90% muscle strength, self-reported knee function on the IKDC greater than or equal to 90, functional performance on all the hop tests greater than or equal to 90. So let's look. The pediatric patients do better than the other two groups, but they don't do very well, right? 69% meet quad strength guidelines. 88% score well on the IKDC. Their hop tests are pretty good, but if you look at all of them, again, in our case, you have to meet all of these criteria to pass return to activity, 31%. Adolescents, 12%. Young adults, 0. Okay? That's what happens when you don't concentrate and measure quad strength. You're fooling yourself. The knee may look good, but then they show up at one of our offices somewhere in the world, and they say, oh, I'm jumping, and anytime I start to jump or run, my knee swells and I get knee pain. Guess why? The shock absorber isn't there. So this is how we start. It's not like you slap a 40-pound boot on them the first day. You start with long arc quads, none to light resistance, 2 to 3 sets, tempo of 3-1-3. And then week 2, we start putting cuff weights, knee extension machine, and then move on from there. Okay. If you have patients who are having a very tough time, they aren't able to manage the load at all, we might consider using blood flow resistance training, restriction training. All right, measure quad strength. There's, again, a very nice article from the University of Pittsburgh, Anthony Sinecor. They compared full arc of motion, partial arc of motion on a knee extension machine, leg press, and handheld dynamometer stabilized with a mobilization strap so that it's not depending on your strength, the strength of the therapist. And what they found was 1 RM on a knee extension machine is the best approximation of a dynamometer. The problem with a leg press is I can do a leg press just with my glutes, even with one leg, okay? So you can completely not use your quads and do a leg press. So unless you're monitoring the quad somehow with like EMG or something else, you have no idea whether they're using it or not during this testing. So if you use handheld dynamometry or a leg press, they both overestimate the strength of the involved leg. So if you better set your percentage, your QI, for progression at 100% or more in order to protect your patients. This is our setup. Look like fun, huh? She looks like she's having a good time. This is Craig Seymour, one of the therapists in our clinic. We do something called a burst superimposition technique, so they're doing an isometric max, and then a quick 10 millisecond burst of electricity is superimposed. And that's how we measure inhibition, which is very important early on. And I think you can see the full dark line here is pre-op. And they're strong, but they have quite a bit of inhibition in that little blip there. 4 weeks, substantially lower, right? 4 weeks post-op. 12 weeks, you see they're back above their volitional activity in that pre-op. But if you look, they're approximating where their capacity was if you look at the inhibition. And then a year, they're way up there with very, very little percent inhibition, okay? And he's yelling. He's the best yeller. Kick, 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 kick. That's what you tell. All the effort, his face is turning red. Okay, here we go. Oh, it didn't work. I have to hit it. Is there any way that somebody up there can just play that? It's upside down, which it's not going to be once it plays. Can you play that video, please? Sorry. They're in there. I'm looking back there, and there's nobody back there. Oops. Okay, so this is a patient 10 days after bone patellar tendon bone reconstruction. She's a volleyball athlete. There's a little arrow at the bottom. No? No? Okay. Sorry, guys. Anyway, she has full extension, flexion, where she can almost touch her knee to her butt. And she can do she owns that range of motion. Her extension is full, and actively it's full, okay? 10 days. No, you can see that she has virtually no effusion. Later, I'll show it to you guys. This is our setup for electrical stem. Again, this is in the practice guidelines, again, that you can download. These are the instructions. This is something really important for when we're moving on, okay? Because from now on, you're going to start, when somebody looks like that patient looks that you couldn't see, what are we doing, right? then you're going to increase loads on these patients, and you really want them to be able to tolerate these loads. So you've got to have a way to measure them. So the two things we use are knee soreness and effusion. We do effusion testing using a sweep test. Again, I can show you guys how to do it if anybody wants to see it. We have in the paper, in the practice guidelines, pictures and descriptions of how to do this test. Knee soreness, we don't really care about muscle soreness, right? Muscle soreness is fine. In fact, we kind of like it, right? Because we know that their muscles are getting stronger. But joint soreness is not. That's an indication that something's amiss, right? Maybe they're doing too much, or they, people, you get that with people who have restricted range of motion, for example. That's once they start weight bearing. So we use these two things as indicators that we're on the right track or that things aren't going well. So you have that patient at 10 days that has full passive and active range of motion, very little effusion. This is Disney World, okay? Hurry up and wait. Rehab is what we're talking about. So it's not that you don't try and get them to these milestones as fast as you can. You do, but then you have to wait for appropriate biological healing. So it's just like Disney World. You stand in line and wait at the ride until you get to the head of the ride, and then you go through the ride with your kids, or in our case, our grandkids, and it's a lot of fun, and then you go to the next one, and you wait in line, and you wait in line, and you wait in line until it's your turn, right? It's exact Disney World rehab. That's what we're doing after that 10 days. And it's, all of these things that we know, right? All kinds of progressions. Continue, I'm going to keep banging this quad strength thing. So our guidelines are running somewhere around 3 to 5 months, 80% quad index, full range of motion, no effusion or knee pain, okay, to start running. Level 1 sports, 9 to 12 months, 90% QI, hop tests, and their proms. So criteria to begin running, here you go. This is from the article in Sports Health. And this shows, we go through this process on a treadmill, then a track, and then finally return to field or court, okay? Instructions about rest days, which there are more of them in between training sessions earlier on, and it gets closer together. And then, of course, they start getting soreness. You have to think about whether you're going too fast. And then this is the test that we use, quad strength greater than 90%, 4 single hops greater than 90, knee outcome survey activities of daily living scale greater than 90, and global rating score, okay? So passing this return to activity screening exam and the running progression means they can get back to practicing, right, to activity. This isn't clearance to return to play. Oh yeah, go back, okay? So another recipe for disaster. So we send them, once they can do full speed agility training without pain or apprehension, we move them on to unopposed practice of sport-specific skills, okay? And when they can do those things, they're on-field, basically on-field rehab is what they're doing now in this phase. Then you add one-on-one practice, opposed practice. This is the danger time when you need to start really paying attention to your patients. This is why on-field, somebody having a rehab personnel on-field is a really good idea. An opponent, except in skiing and doing a landing from gymnastics, for example, no ACL injuries happen without an opponent. That doesn't mean the opponent is touching you. It just means there's an opponent somewhere on the field, somewhere in your view on the court. So that is a time to watch your patients and see if they're reverting to movement patterns that you worked them out of, right? That they'd practiced and gotten out of. The opponent shows up and all of a sudden they get back into those movement patterns. And you have to step back, warn them about it, first of all, and then give them feedback and help them work through that. And then finally, they get to full practice with the team. So this is the description of our patients at inclusion. we had 167 patients who had early ACL reconstruction. We had 30 who had delayed ACL reconstruction, meaning after 6 months. Okay, and then 65 who had progressive rehab alone. And this is at 5 years, looking at where they ended up. And let me see what we have here. No, I want to go back. So what you can see are that this is not a randomized trial. So let's start right there, right? These patients chose their path. Those who chose progressive rehab alone were older, right? I don't think that's surprising. And slightly more female, but otherwise they're pretty much the same, okay? Younger and more female. So here are 2-year outcomes benchmarked to the Multi-Center Orthopedic Outcomes Network, which is a US registry. And our 2-year IKDC scores were 13 points higher than Moon's. The KOOS scores were all higher, and substantially so in some cases. And our return to sport rate was about 10% higher. From these 2-year data, Hege Grindum, one of our former graduate students in Norway, found that only 6% of the patients who passed these return to sport criteria before they returned to level 1 sports suffered re-injuries, compared to 40% of those who didn't pass. Okay? Although quadriceps strength symmetry is part of that return to sport screening exam, quad strength just by itself, more symmetrical quad strength significantly reduced the risk of re-injury. And once again, those who returned to level 1 sports had 5 times higher risk of knee injury than those who did not. And this is the last one, and this is biology. I know I'm going over here, so I'm gonna pick this up a little bit. The risk of knee re-injury was reduced by 60% for each month the return to sport was delayed until 9 months. So passing return to sports test batteries was associated with a decrease of further knee injury by 72%, odds of any ACL injury by 75%, and decreasing the odds of graft rupture by 78%. So this is a couple of weeks ago, or a month ago, I guess now, Maria Peterson, our student in Norway, defending her dissertation, which is the 5-year outcomes. And if you look up here, what you'll see, early ACL delayed, progressive rehab alone, IKDC, quad strengths are off the charts, right? Which is the second bar. Hop tests are all really good. And then for us, something that was really important is that only about 6% of our patients are not participating in any physical activity. I'm going to go past this. And in terms of radiographic outcomes, this is zero. You can see 0 is the big one. No evidence of any OA. But no difference among the 3 groups. So patients with ACL injuries who had been active in jumping, pivoting, and cutting sports prior to injury, who followed our decision-making and treatment algorithm, had good 5-year function and high sports participation rates, more than 95%, and then 57 to 61 still at level 1 and 2. And then I went through all this. Understandably, the choices made differed by age and participation in 1 versus 2. So we think this shared decision-making paradigm with a little bit more extensive pre-op rehab is a gold standard. So ACL sports, quickly I'm going to go through this. The ACL sports, the athletes were eligible for this study enrollment if they were regular participants in level 1 and 2 sports, planned to return to their pre-injury level of activity, had 80% quad strength and 0 to trace knee effusion. And one group did a sort of standard rehabilitation, and another group we did the perturbation training, neuromuscular training. Turned out there was no difference between the 2 groups. But fortunately, both arms had a secondary prevention program in them. So we had an opportunity to see what does a secondary injury prevention program do with these patients. So the last step is always to try and prevent re-injuries. So we did this progressive secondary injury prevention program, right? This is from our protocol paper in BMC musculoskeletal disorders. And this shows, there were 10 sessions. So what did we do in sessions 1 to 3, 4 to 6, 7 to 10 of the Nordic hamstring, standing squat, drop jumps, triple, single leg hopping, tuck jump. We did agility drills, continued with quad strengthening. And these are the numbers on ACL sports. 75 of 79 patients passed return to sport by 1 year. 100% returned to play between 9 months and 2 years. And these are their results. Quad index, 102%. All the hops, at least 100%. The KOS, ADLS, global rating, all were really high. And if you look at the last one, the Marks activity rating, the Marks has a highest score of 16. So that's an activity rating that you would see in somebody who's a team player. Okay? And these are, the one on the right has comparisons to Moon, again, and Delaware-Oslo cohort. And what you can see is this group we did substantially better than Moon with Delaware-Oslo, but this does substantially better again. Okay? So all young athletes passed return to play by 2 years, 100% return to play, 87% at their self-reported pre-injury activity level between 9 months and 2 years. So our denominator for this injury is 100%, which is what I talked to you at the very beginning about that people assume about the others. We had only 1 injury in the men, that was at 23 months, and 9 in the women, 4 grafts and 5 contralateral. So they were substantially lower percentage. So what are we talking about here? Graft healing and incorporation proceed under the surface. Dr. Constance Chu from Stanford University calls this process silent. And healing based on these MRIs takes a couple years. Okay? The question is, should we begin using this mounting evidence from imaging in this process about our clinical decisions? It's an open question. I don't have an answer. But should there be strict time restrictions if all criteria are met, and what should they be? Well, biology matters, but we have player age. Sports physios, you know that you're making decisions based on a lot of different things, not just one. So age, experience, level of play, talent, importance of the competition, time left in the competitive season all play into this decision. But the evidence says, and we're not talking about necessarily professional athletes, but for pretty much everybody else that makes up the vast majority of our clinical practice, no return for 9 months. And for those under 18, we hold them out for a year. And we prepare them ahead of time for that. So here are the clinical recommendations from our paper, which is summarized. They're all A or B ratings except for return to competition should be stepwise, right? That's just consensus. So return to play after ACL level 1 without re-injury, prehab beyond a quiet knee, early rehab, day 1 or 2 after surgery, criterion-based progression, pass stringent criteria for running and return to activity, do a secondary neuromuscular and strength training prevention program before you send them back to play, and they pass on-field and on-court progression all the way through using soreness rules and effusion testing, and no return before 9 months, and if they're under 18, 12. So this is Delaware. It's on the east coast of the United States, midway between New York City and Washington, D.C., about 2 hours from each, a little bit less to D.C. And that's important because those 2 people in the middle, our president and first lady, are proud graduates of the University of Delaware and live in Delaware. So now everybody in the United States knows Delaware is a state and not the capital of Maryland. So this is our campus, and that's our STAR, our building for physical therapy, our labs and our clinics and classrooms. So thank you very much. Thanks. Questions?
Thank you very much.
You're welcome.
Again. Thank you very much, Lynn.
You're welcome.
You know, in Switzerland, we're also looking for the bad wolf, you know?
The bad what?
The bad wolf.
The bad wolf, yes, yes. I
So-
think that's the origin of the story, right?
And I think we know where it is. So, are you ready?
I am.
Are you ready for questions
Sure.
from the audience?
Yeah.
Please. Liebe Kolleginnen und Kollegen, hat es eine Frage, die jemand stellen möchte aus dem Auditorium, oder gehen wir direkt zu Slido? Bitte.
Hello. Any indication about the ratio between quadriceps and hamstrings during rehabilitation?
Yeah. So there's people say, how do you normalize your quad strength, right? If you look at quad hamstring ratios across, especially across sports, body types, sprinters versus basketball players versus whatever, there's no normal ratio, right? So there's that people have talked about all these, spin around a lot of different ratios. If you're going to use it, just look for it to be getting, we generally with ACLs don't have a lot of hamstring weakness, even with hamstring grafts, by the time we're making these return to sport decisions at around 6 months. So I think you just need to look at, again, per kilogram of body weight is another problem sometimes. But quad hamstring ratios, there is no science behind there being a normal quad hamstring ratio. Why there should be an agonist-antagonist normal number, given the range of sports that people play and range of body types, it doesn't make sense. So, long-winded answer, sorry.
Thank you very much. Now we go to one question from Slido, please.
Yeah. What do you think about conservative treatment if people desire to return to pivoting sport?
Okay, well, that's a good question. We let the patients make that decision, and it turns out they make a pretty good decision, right? The youngest pivoting athletes generally choose reconstruction. But I can say we had more, 60% of the group that chose early ACL reconstruction were level 1, and it was flipped in the non-op group, in the progressive rehab alone group. And every one of the people who had ACL reconstruction intended to return to sport, or level 1 sport, but they didn't all do that, right? And most of those folks who chose rehab alone intended to return to a level 2 sport, and almost all of them did that, but a whole bunch returned to level 1 sports without re-injury. So I really think and the number one reason why they chose to stay in the rehab alone group after that protracted rehab is that their knee felt stable, right? So you give them a chance to figure it out, their knee to figure it out, they make a good decision. But I don't think, that takes a little bit of time to figure that out. So give them all the information and let them make an informed decision. That's my...
Thank you so much.
Thank you very much, Lynn. Thank you. We have to go a little bit further. We're a little bit late. Thank you very much.
My fault.
Ladies and gentlemen.
It's okay.